Good afternoon. Thank you for having me here today. I've been asked to talk about prescription drug monitoring programs and other state-level strategies for addressing opioid-related harms. Given the multifaceted drivers of opioid-related harms, it's going to be necessary to think about different complementary strategies that can be implemented in tandem to address the problem. And so hopefully today I can give you some insight into the potential impacts we might achieve if this multitude of strategies were implemented. In particular, I'm going to focus on 4 strategies that can be implemented at the state level and have promising levels of evidence supporting them. They include prescription drug monitoring programs, or PDMPs, public and private insurance strategies, clinical guidelines, and state legislation. Each of these strategies target inappropriate prescribing in some way as a driver of opioid-related harms. Importantly, I'm not going to be talking about naloxone distribution or increasing access to medication-assisted treatment, although those are also evidence-based strategies. Other panelists will be talking about those today. So in 2014, my colleagues and I conducted a systematic review of state and system-level strategies to address prescription opioid misuse and overdose. And we concluded that overall, there were a few rigorous evaluations of strategies that had been conducted. The evaluations tended to assess knowledge and behavior rather than health outcomes. There were methodological limitations to the studies, and as a result, the overall level of evidence for these strategies could be considered to be low. However, we did identify some strategies that could be considered promising and worthy of implementation, particularly when implemented and evaluated to identify what the potential impacts might be. New evidence has emerged since 2014, and I'll be talking a little bit about that, which might bring the level of evidence for some of these strategies up to moderate, but it is important to acknowledge that this is an area that's still worthy of support and attention. So first, prescription drug monitoring programs, and the conversation just before the session teed this discussion up nicely. PDMPs require submission of information on prescriptions filled for controlled substances to a central office by pharmacies and in some states by dispensing providers or physicians. This information can be accessed by providers to identify what substances patients are being prescribed and to understand whether they might be visiting multiple providers or multiple pharmacies to obtain their prescriptions. Depending on the structure of the system, prescription history reports can be accessed by stakeholders such as state insurance agencies, healthcare licensing boards, public health departments, and law enforcement to address aberrant prescribing. Some state laws allow for public health agencies to access de-identified data in order to conduct epidemiologic analyses, but overall states vary widely with regard to the categories of end users and the conditions under which they're permitted to request and receive prescription history reports. Currently, there are PDMPs authorized in 49 states. However, they are not fully operational in all, and their quality and utility does vary greatly across states. So the question generally is no longer about whether to adopt a PDMP, but it's really about maximizing its use. More than 2/3 of PDMPs are housed in public health agencies or sister health agencies. Other agencies in which they're housed include law enforcement and in regulatory or licensing agencies. PDMPs are useful in a multitude of ways. They can be used as a surveillance and evaluation tool for clinical decision-making by law enforcement and also by state regulatory bodies. For example, the Prescription Behavior Surveillance System collects PDMP data from 11 states. The system provides population-level measures of inappropriate and aberrant prescribing and can help serve as an early warning public health surveillance tool. So for example, it can help identify changes in prescribing patterns or indicators of risk associated with new drugs or with new formulations. States are newly investigating in data linkage activities with PDMPs to allow for more sophisticated surveillance. So for example, in Wisconsin, they're actively linking PDMP data with vital statistics data, hospitalization, and EMS data. And they can use these linked data for better epidemiologic analyses. In terms of clinical decision-making, states are working to integrate PDMP reports into the electronic health record so the information is more readily available and easily accessed at the point of care. So for example, Ohio has been working to integrate the NARCS check risk score in the electronic health record, which provides an assessment of the prescription history based on PDMP data for the provider. To assist with investigations, North Carolina sends reports from their PDMP to their medical board for prescribers that have multiple deaths on their roster or who are in the top 1% of MME prescribing. The PDMP Center of Excellence at Brandeis University has outlined best practices for PDMPs, providing some evidence supporting their identification. And best practices include things like making PDMPs more real-time or reducing the data collection interval, having universal registration and use, and active management, meaning that there are proactive prescriber outreach reports and unsolicited reporting to regulatory bodies. And there's a series of other recommended practices that you can see here. So PDMPs are considered to be promising strategies based on descriptive before and after studies and time series analyses. There have been mixed findings across studies, with some studies illustrating decreases in prescribing as well as a decrease in multiple prescribers and pharmacies. More recently, an interrupted time series analysis of multiple states revealed a significant reduction in opioid-related overdose deaths after implementation, with greater reductions when a higher number of scheduled drugs was included in the system, and the data updates were completed at least weekly. However, earlier studies have shown no impacts on mortality, so this suggests that evaluation findings might differ depending on the nature of the systems being evaluated, and that findings might change as systems change and continually improve. The next strategy to consider is public and private insurance strategies, such as those implemented by state Medicaid programs and pharmacy benefit managers. Such strategies include prior authorization, drug utilization review, and patient review and restriction. For this last strategy, for example, this requires patients to use one prescriber or pharmacy for controlled substance prescriptions. Again, these strategies are considered promising based on before-after studies, time series analyses, and RCTs. Although changes in mortality outcomes have not yet been documented, decreases in ED visits, polypharmacy, high-dosage prescriptions, and number of prescribers and pharmacies have been illustrated. There really have not been that many rigorous evaluations of this type of strategy yet. But for example, in one RCT, patient outcomes were examined after providing a cover letter to practitioners based on a drug utilization review or providing general prescribing resources. And the investigators found that there was a significant reduction in the number of prescribers, number of pharmacies, and percentage of filled prescriptions for those providers that received that drug utilization review letter about their patients compared to just general resource provision only. And evidence is continuing to emerge on the effectiveness of these sorts of strategies. I know as a peer reviewer for journals, I'm seeing more and more of these coming in, so I anticipate in the coming years we're going to build the evidence base for these strategies quickly. States can also issue guidelines on opioid prescribing. In March of 2016, CDC released the guideline for prescribing opioids for chronic pain, and we've heard that states are starting to adopt the recommendations into their own state guidelines. Guidelines typically focus on acute or chronic pain or both, and provide recommendations related to initiation, dosing, monitoring, and discontinuation of opioids. They also typically include information about alternative or complementary treatments. And importantly, these guidelines are typically accompanied by implementation efforts. So guidelines as a document don't implement themselves. There needs to be some sort of strategy paired with them, such as education, like continuing medical education credits or academic detailing. So clinical guidelines, again, are considered promising based on before and after studies, time series analyses, and RCTs. Moderate knowledge improvements have been illustrated for providers, but with sometimes limited use of recommended practices. But implementation does appear to increase when training and education efforts are implemented along with the guideline. Effects do tend to be detected with more concrete outcomes, such as with dosing limits, limited use of extended release opioids in opioid-naive patients, and with urine drug testing. So one example, Coachella and Bateman illustrated lowering of initial dosages, slowing of dose escalations, and increased PDMP use after an academic detailing initiative based on a guideline. And they also found a concurrent decrease in overdose deaths in the area in which the initiative was implemented. And significant decreases in death rates have also been illustrated in New York based on an academic detailing campaign that was based on a guideline. And the final strategy I'll talk about is state legislation. So states have passed legislation in an attempt to reduce inappropriate prescribing through pain clinic regulation and also to increase willingness to seek assistance, such as for naloxone administration after an overdose occurs through Good Samaritan laws. Evidence of effectiveness of strategies, again, comes from descriptive and time series studies. Evaluations of Good Samaritan laws have illustrated a greater comfort among those who misuse drugs and their friends and family in calling 911, and a greater likelihood of reporting behavior when immunity from prosecution is offered. And in Florida, a decline in opioid prescribing and death rates was detected after passage of a pain clinic law, which was also implemented in tandem with the prescription drug monitoring program and other enforcement efforts. So given the level of evidence for these strategies is promising, it's easy to identify research gaps. There's many questions that are available to be answered, but given the focus of this panel, I chose to focus on these three. So the first is, how can PDMP data be best leveraged for surveillance and etiologic investigation? And in particular, how could PDMP data be used for post-marketing surveillance of opioid medications? Another question might be, what systems-level translation and improvement strategies can enhance adoption and use of recommended clinical strategies, including PDMP use? So, for example, could including education on PDMP checks and the CDC guideline recommendations more broadly in REMS improve use and utility? And finally, which insurance and pharmacy benefit manager interventions and state policies change prescribing behaviors most effectively while supporting effective pain management? I only talked about two legislative strategies today, the pain clinic regulation and Good Samaritan laws, since those have been evaluated, but there's a whole host of other state legislation that's currently being implemented that hasn't been rigorously evaluated yet, so there's a lot of questions to be answered about that. That's it. Thank you.